All right, great. Hi, everybody. Welcome to the Women's Wellness Forum. I'm just going to go ahead and give a couple seconds here just to have a few others join on, and then we will get started. Well, great. I want to give a welcome. My name's Gabi, and I'm so excited to be a part of this Women's Wellness Forum today. We will have this recorded and emailed to everybody who registered. So feel free, if you have to pop on late, we'll be able to send this out. The second thing that I want to have is because we do have a live Q&A session with our specialist here. Go ahead and drop that into the Q&A box, and I will be sure to pop up and ask the questions at that time too. We just have a couple things to cover in regards to fibroids, what they are, and types of treatments, and we will get started. So I want to thank our three specialists and experts that are here. These are some of their highlights that we have in addition to who they are as people and providers. So we start with Dr. Amin Astani. He is our founder for the North Star Fibroid Clinic here within Golden Valley. And he's a women's health specialist with over 12 years of experience. He is a UFI expert, hundreds of procedures that have been performed, and additionally has been nationally recognized. In addition to, he's a patient advocate, passionate about expanding treatment options and improving quality of life. Next, we have Dr. Catherine Grand. She's an OBGYN with Metro Partners within the East Metro of the Twin Cities. She's a specialist expertise in minimally invasive gynecology surgery for over 13 years. She's passionate about helping women understand their options and empowered in their care. She's also named a Minnesota Monthly Top Doctor in Minneapolis St. Paul Magazine Top Doc Rising Star. The last pillar that we have here is Kelsey Nowak. She is the founder for Candor PT and Pelvic Health. She's a specialist in pelvic health with over 18 years of experience. She's passionate about finding the biomechanical and psychosocial drivers for why the symptoms are occurring and partnering with clients to educate, help maximize strength, and feel at home in their bodies. Wonderful panel that we have here just to showcase, and we'll go ahead and get started. First, I want to have Dr. Grand just expand into what are uterine fibroids and how common are they?
Uterine fibroids are benign tumors of the uterus that are composed of the smooth muscle cells and the fibrous cells of the uterus. They can really vary in size from a centimeter to 20 centimeters and are really very common, with about up to 70% of women experiencing fibroids by the time they reach menopause.
Great. We have an image of additional fibroids and where they're located within the uterus too, just as an educational point that Dr. Grand highlighted. I was going to ask too, with fibroids and their commonality, what are some symptoms that maybe women should not ignore?
I think the two most common symptoms with uterine fibroids are abnormal bleeding and bulk symptoms. So pelvic pain, pressure, discomfort. They can have urinary urgency, urinary frequency, pain with intercourse. I think any symptom that's persistent and causing distress is worth looking into, but definitely, looking into abnormal bleeding. Fibroids can be the cause, but there are also other causes of abnormal bleeding that you want to rule out, like a uterine cancer or other causes.
Absolutely. The question I want to ask Dr. Astani here is, what are some of the disruptive symptoms of fibroids that you come across?
As Dr. Grant said, fibroids are very common. So most women have them not, right? And they grow slowly over time, and the symptoms grow slowly over time. It's not typically not a sudden change that, oh, last week I didn't have pain, this week I have pain. A lot of women grow with those symptoms and get used to it and just tough it out. And they don't have to. They may be coming from fibroids, and many treatment options that can be easily treated. As Dr. Grant said, there are typically two groups of symptoms. One from bulk symptoms, the size symptoms that are large enough, they can push on for example, bladder in the front, it can cause urinary issues. If they push on the rectum on the back, they can cause constipation issues. On the sides, it can cause pressure and pelvic pressure, pelvic pain. Or it could be related to the way they respond to the fluctuation of hormonal, like female hormonal fluctuations throughout the menstrual cycle. And that can mean that the menstrual bleeding is prolonged, it could be heavy, could be disruptive, and sexual activity can be difficult. And all of those things may be from fibroids, and all of those things have treatment, and we can look into them. And yes, some of those symptoms are non-specific, can come from other things. Rarely they can be worrisome, such as cancer, but that's not common. But that's why the physicians here, the experts here, look into all the possibilities and then come up with the best treatment option for those fibroids.
Absolutely. I want to ask Kelsey this because when it comes to pelvic PT and trying to look at maybe a start of symptom 2, how can fibroids affect pelvic floor function and quality of life?
Yeah, thanks for asking. It's lovely to be here and engage in all of this with you guys on this panel. So thank you for having me. So many different ways. The chronic back pain that never goes away, the chronic hip pain that you just like, I've been through therapy 3 times, or I go to chiropractic care and it just doesn't help. Fibroids can have mass to them. They can have weight. Your uterus can definitely improve in its volume and size, and tension can be upregulated in the pelvic floor structures. That can come with a whole host of incontinence or pain or constipation, sexual dysfunction. So we'll look at all of that in context with what might be going on. There are numerous patients that I've seen in clinic that their continual sacral pain low in their back, at the back of their pelvis, is actually due to a fibroid and not due to a structural problem with their back. So anything that's lingering in that area, I call it essentially from your belly button down, and even sometimes they can grow above that too, depending on their size. But if it's pain that's unrelenting and just not going away, cyclical in nature and affecting that quality of life, is definitely when we'll look at higher level intervention.
For sure, quality of life and then inhibiting in order for the next intervention and step. I wanted to ask Dr. Gran, then, are fibroids always something that need treatment?
They do not. And oftentimes, I think the majority of them are asymptomatic and people may not know they have them. And so if patients have small fibroids that do not cause symptoms or discomfort, they're not causing abnormal bleeding, watching them is a very reasonable option.
Mhm. When monitoring too with Dr. Astani, how do you determine whether a woman has fibroid symptoms and they're actually being caused by fibroids?
Well, when they have the symptoms and they seek treatment or consultation, the diagnosis of fibroid or looking into if somebody has fibroid or not is fairly simple. It's actually very simple. Either with ultrasound or cross-sectional imaging, such as CT or MRI, can show fibroids. Ultrasound is typically the fastest and quickest that you can obtain and can tell us if somebody has fibroid, how many and how large they are. Sometimes people may require MRI to better delineate number of fibroids or differentiate them from other causes. But typically the first step is a simple ultrasound.
Right. With the symptoms, just because we keep going back, just educating about what symptoms might be having before the fibroid diagnosis. Kelsey, what symptoms might actually be related to the pelvic floor rather than the fibroid itself?
A good question. It can be a little bit of a tricky thing to evaluate out in absence of imaging. So anytime in pelvic health that we're suspecting might be something going on, we definitely refer back to our colleagues that can order that imaging and make sure that that's not there. But pelvic floor tension, some people develop extreme pelvic floor tension, don't even know that they really have it, similar to, I didn't even know I was grinding my teeth or clenching my jaw that whole meeting long, but it can kind of become their baseline of dysfunction in response to either weight or mass or just chronic pain that might go on in that. We can end up with some gripping syndromes of the pelvic floor, which can then affect urination, having bowel movements. sexual function, decrease orgasm arousal, penetrative type options. So all of that can kind of become a host of that, which then again leads back to the quality of life. There's unfortunately a large statistic out there that up to 45 or 50% of females in perimenopause or menopause will actually stop exercising due to either incontinence, pain, or some other pelvic floor disorder. And so we try to identify those as quickly as we can to then partner with that patient or that client to develop a program through that.
Perfect. And that leads us into the next section too, actually, about treatment options as a whole. When we explain this, and I thank all three of you for your explanations and just details of what to look for. I want to dive into the treatment options next. With Dr. Grant, how do you determine, with a patient if they should consider if it's medication, surgery, or a minimally invasive procedure, say, for
Yeah.
fibroid?
Well, I think you kind of hit, you explain that there are many options for fibroids. I mean, I think there's not one perfect option for people, and there are a number of things. You could do observation in terms of medications. There are a number of medications out there, being an IUD, TXA, some of the other medications, and then a number of surgeries, either a myomectomy, doing a hysterectomy, and some of the more minimally invasive procedures. And so how I, approach it with a patient is, their overall clinical picture. What's their health? What surgeries have they had in the past? What are their symptoms? What are their goals? Are there things that they're interested in looking into? So I think a number of those factors dictate which way you go. But sometimes people have medical conditions where if they could avoid going under anesthesia and they may have an easier recovery and handle it better. Other times they've tried a couple options and then they've failed and we go to a more definitive procedure. So I think it starts with really getting a comprehensive evaluation of patients, what they've tried, what their symptoms are, and really what their goals are with treatment.
For sure. That's really good insight, taking a bigger, look at the picture and what the patient wants, I guess, and that goal and that's there. What I want to kind of start off too is when we look at, the first kind of basis is if there isn't an intervention, I want Kelsey to kind of explain how pelvic PT help works first, and then kind of going into other treatment options.
Yeah, absolutely. So sometimes we see people because of a pain driver and they have no idea that a fibroid or a dysfunctional other diagnosis might be part of it. They're just in pain or they're still leaking years and years out from delivery, or they never leaked after having their baby, but now all of a sudden it's coming back into life in perimenopause or menopause. So trying to determine the why. So clinically in public health, we get to spend a lot of time with patients. In my practice, we do a 75-minute intake and a 60-minute follow-up session, which is so lovely to be able to learn all about their goals and what they have available to them for treatment options. And then we always have great team members in our back pocket, like your guys' team at North Star Fibroid Clinic and fabulous OBGYNs in Dr. Grant's world. And that can all be very helpful to kind of see how that goes through. But we start with biomechanics and we look at lumbosacral mobility and core strength, hip strength. And then we do get as an invasive, if people are okay with that, with internal vaginal or internal rectal assessments to determine the function, the coordination, the relaxation of the pelvic floor musculature and how that ties in. And then based on clinical reasoning and kind of discussion, we formulate a treatment plan, and there's a ton of education, which is so fun to be able to spend so much time with patients to really help it customize to what their needs and wants are.
Awesome. Amount of time just to learn their story, really hear them out on the symptoms that they're struggling with, obviously, in order to find the treatment option that's available.
Yeah, and allowing them to tell their story start to finish, I think is hugely important. So I appreciate all of you guys that are on this panelistic view that you take that site too.
Absolutely. If anything, we want to empower women on their options that are here as readily resource. Dr. Astani, walk us through what the IR role does for fibroid treatment.
That's an amazing question. But before I answer that, I see a very good question from one of our attendees that is asking, is there anything I can do via diet or supplementation to slow the growth of fibroids or make them shrink? Dr. Grant, is there any option, diet, supplementation?
There aren't really any clinically proven supplements or diets. I think that, so not, I think obesity and hypertension are risk factors for having fibroids. And so kind of overall general health is helpful.
Right. So the fibroids are not because of what women do. It just happens not because of what they ate or what they did. It's normal, as Dr. Grant explained at the very beginning, normal tissue of the uterus has grown abnormally because of hormonal stimulation. They are benign, they're not malignant, and they typically are not result of what you have ate, or you can't do some, like with diet, you can't slow the growth. Typically, that's not the case. There are many treatment options. That's the good news. If you have fibroid, there are many, many treatment options, including what we can offer in IR world, in interventional radiology. It's a minimally invasive procedure. We call it UFE, or uterine fibroid embolization. It's a mouthful, just means that those fibroids that are there, we go through the vessels, we block the vessels so they shrink. They don't get nutrients anymore. Just like when somebody doesn't get enough diet, they lose weight. Those fibroids don't get the blood flow, they don't get the nutrients, they start losing weight. This is one, it's a good option for most patients, but this is one option in our toolbox that we determine by multidisciplinary approach, which is the best way of which option, which treatment is best for which patient. Somebody may require a very immediate treatment. Immediately, they have to debulk the fibroid, and surgery may be the best option because with UFE, the shrinking happens over weeks and months. It's a slow process, slowly shrink. It took years to grow. They took months to shrink. For some patients, and Dr. Grant said, they may have trouble with anesthesia. They can't go over the general anesthesia or to the operating room, and then we can do UFE for them because it doesn't require anesthesia, for example.
Absolutely. With looking at surgery, Dr. Grant, when do you think a myomectomy is a better option versus hysterectomy as an additional option?
Yeah, there are a couple factors. One kind of the first critical one is if people want to have children. If you have a fibroid and you want to have children, the myomectomy is the route we go. And then also looking at the number of fibroids, the size of fibroids, age, and fertility, those can affect it.
Absolutely. I think with looking at, the I would say importance of preserving the uterus, even if pregnancy isn't planned. How do you feel about preserving the uterus as a whole?
I think that is really a patient driven conversation. And I think we can remove fibroids, and it is a risk factor of them coming back. So again, it kind of depends on if there's one fibroid and patients want to maintain their uterus. There are, many reasons why people may choose that. But so I think that it is not necessary in terms of it's a good option if you have multiple small fibroids and the risk of recurrence. A hysterectomy is the most definitive way to deal with it and not have them recur. But a myomectomy can be a very good option given the overall picture.
Mm-hmm. For sure. With I would say kind of the expectation for patients too, when I think about the options, of the removal of fibroids with uterine fibroid embolization, what results should patients realistically expect, Dr. Astani?
Uterine fibroid well, there are plenty of options, treatment options, right? And each one is good for a specific group of patients. Those who go through uterine fibroid embolization, if you have selected the patient well, meaning that UFE or uterine fibroid embolization is a good treatment option for them, From technical standpoint, we are successful in nearly all the cases we do. From clinical standpoint, meaning that the patient's symptom resolve, about 80%, 90% of patients have significant improvement in their symptoms. And significant improvement meaning that they're, for example, if the problem was a long period or heavy bleeding, those improve over time. But again, the effect doesn't show up immediately after the treatment. It's a slow process over a few weeks. Typically by 3 months post-procedure, the fibroids have shrunk and have responded to the treatment enough that people see the difference.
I was going to ask too, if, the misconceptions about UFE, like what do you hear the most often when it comes to misconceptions about the treatment?
Well, the number one problem we have is lack of awareness. A lot of people don't know such a treatment exists. So I have a question here that I see one of the attendees have asked, and it is, does the fibroids grow after treatment? And the answer is depending on the treatment. If you take out the uterus, obviously there's nothing left for the fibroids to grow. That's it. You're done with it. The fibroids are not going to come back, right? And many other things don't come back with it, including like menstrual bleeding. If you do myomectomy, and Dr. Grant can allude to that, if those fibroids are large enough that it's causing problem and is approachable with myomectomy, meaning that you can easily get to them, you take them out, and the rest of the uterus is there, yes, those tissues may respond to the hormones, but it takes years, decades for those small tissues to grow enough to be large enough to cause trouble. You still have fibroid tissues, they respond to hormonal stimulations and they grow. So whenever somebody has fibroids, let's say that 2-3 fibroids, almost always they have smaller fibroids, but they're too small for us to see, right? If you give them many years of hormonal stimulation, they may grow and they may have more fibroids. And that's the same for myomectomy. If there's normal tissues left, they may respond to hormonal stimulation, monthly hormonal stimulation, they may grow and they may come back. The same is true with UFE, because UFE doesn't take out the uterus, right? We still have normal tissues left. And over years, those hormonal stimulations may grow some of the fibroids back and then they come back. But here's the thing. If you are, 40 years old, for example, and you do treatment, and the fibroids that we don't see and they want to grow and come back, take 10, 15 years to come back. By the time they want to come back, it may not be an issue for them, because after menopause or hormonal stimulation fluctuations go away and the fibroids stop growing and they naturally start shrinking.
With the hormonal changes that happen usually at that time frame.
Right. Yes.
That's great. I think we covered a lot, and I appreciate you looking in the chat here too, just to address on what kind of topics we're talking about. One other additional is, does an IUD need to be removed to have the UAE procedure?
Specifically for UFE, yes, we want the IUD to come out because IUD is a foreign body in the uterus, and when we change blood flow to the uterus, we don't want to create an environment for infection to happen. So yes, IUD comes out, we do the treatment, and depending on why they had the IUD may go back, or they may not need IUD. If they had the IUD for heavy bleeding, to control heavy bleeding, they may not need to have the IUD inserted again. But if they had it, for example, as a birth control measure, they definitely need to have it back in, because UFE doesn't stop you from getting pregnant.
Great. Leading into pregnancy, I want to throw this question out across to all of you. Can you, get pregnant after fibroid treatment?
I'll start. You definitely can get pregnant after fibroid treatment. I think many people have had any of the various treatments and are able to go on and, spontaneously conceive and have a spontaneous pregnancy.
I want to echo that. Yes, you can, unless you take the uterus out. Yes, after fibroid treatment, you can get pregnant. And sometimes infertility or getting pregnant and not being able to keep the pregnancy is because of fibroids. If the fibroids are large enough that are distorting the canal and pushing on the embryo, for example, it may be difficult for the uterus to keep that pregnancy. And so after treatment, not only you can get pregnant, in certain cases, it actually can help with fertility.
Go ahead,
That's
Kelsey.
their scope. I don't do a ton with helping folks become pregnant after. We can definitely work on if there's pain involved with pelvic floor tension, and that's prohibitive then for sexual intercourse to then occur. Yes, absolutely, that's my lane. But the actual like what the uterus is doing, I'll leave that to them. Yep.
And I do want to just kind of comment on pregnancy after treatment of myomectomy. I think there is some limited research, and I think this is really an area that it deserves a conversation with your provider if you're getting treatment for fibroids and you're seeking a pregnancy afterwards. I think there are risks and benefits. A general consensus is that an embolization is a relative contraindication to pregnancy. But again, kind of our data on can you have a successful pregnancy? Are there risks? Does it affect the hormones after the procedure? And then what are the risks of pregnancy in terms of miscarriage, postpartum hemorrhage, abnormal placentation of the uterus? There are risk factors for it. So I would just say, this is one I really think is important, where if you're looking at getting pregnant, meeting with a provider, clearly stating you want to get pregnant and really understanding the risks and the benefits of the different options is worth time and energy.
Completely. I'm so glad that you highlighted that, Dr. Grand, just to have conversation about it too, for the expectations that are placed for the patient's goal. And, one huge thing I think across the board is with all three of your specialties. I think that sometimes people look at, different specialties as being competitors versus it being a collaborative front in order to understand what each patient's goal is. So I want to ask all three of you too, like, how do your specialties all work together when caring for women with fibroids?
So for me, I think that often it's a stepwise approach. People may do 1, 2, or 3 treatments often, and again, depending on the patient, but you may start with a medication, a lower intervention with lower risk. And I think, you may get counseling and decide that an embolization is the proper procedure for you. And I had a patient where they had all the proper counseling and chose to do an embolization, and then a fibroid had kind of pedunculated into the endometrial cavity and got referred back, and then needed a more minor hysteroscopy to remove that fibroid. So I think educating patients about all the options and then working together when you have questions in terms of individual patients and what may benefit them.
Great.
I think, as you mentioned, collaborative work is the best way forward. There are many options that there are treatment options that Dr. Grant does that I don't do, and there are options that I do and Dr. Grant doesn't. And you have to have collaborative work to provide the best care for our patients. And I encourage our patients to actually seek that kind of practice, that there is a collaborative effort, or actually go to different specialty to hear different perspectives. I want to go back to one quick thing you said about pregnancy and infertility. Is very true. We don't have enough evidence to say something for sure as a fact about pregnancy after UFE, for example, just because it hasn't been studied in a research setting for a long time to see if somebody gets pregnant or not. There has been multiple small studies. One early study, initially, we thought that UFE may be they were excluded from studies. It wasn't a contraindication, it was a contraindication to be included in the studies because we didn't know effect of UFE and on pregnancy. So early on, like late 1990s, early 2000s, in all the studies that were performed, the pregnant women or those who wanted to get pregnant were excluded. But since then, there have been multiple small studies that have shown that people get pregnant. For example, there was one small study that showed the rate of pregnancy after UFE was 40% compared to general population that was 30% in that study. But there's a newer publication, less than a year old, late 2025, that was a meta-analysis. I mean that like put all the smaller studies together and tried to come up with a final summary. It was a 20-year clinical evidence study that showed, I'm going to read from the final conclusion. It says UAE, or uterine fibroid embolization, preserves fertility in 50% of selected patients. So their conclusion was 50% of patients who had UFE still got pregnant. And there wasn't another group that actually didn't get treatment to see what's the fertility rate in those. And those who wanted to get pregnant, or those who got pregnant, not necessarily wanted to get pregnant, but got pregnant, average 14 months after the treatment, they got pregnant.
New research and treatment options just continue to come out, which is great. That's exactly how we want to see science evolving for women's care, especially when it's in regards to fibroids and how common they are. Jumping into,
So I just want to, I mean, I think it's important that in terms of their elements of can they get pregnant? And so I think there's the new evidence is showing people can get pregnant, but just also getting kind of the data of not just live births, but the risks in the pregnancy and postpartum period. So I think even how the embolization is done, it seems when I came and watched you, it's a much more targeted procedure to the individual fibroid than just the opening of the uterine arteries. But again, I think really we need more research on it. And so, why it's important to kind of get all the information.
Absolutely, yes.
Great. Kelsey, I want to seg us into kind of the recovery and quality of life after talking about some of the treatment options and where pelvic PT comes into play here.
Yeah.
When should pelvic floor therapy really be a part of treatment? Is it, before? Is it during recovery? Kind of walk us through that.
Yeah, awesome. Thanks so much. I love that question. Emma, hopefully I can answer most of these parts of your question. If not, just holler out again and I'll try to type an answer to it as well. In the Q&A. Emma, you asked if pelvic PT should start before procedure. I will shout from the mountaintops. Still, I am no longer able to do this job. That we set these other lovely clinicians up for all the success when we get patients in here before to help them plan. There's a lot of planning that goes in. Now, in interventional radiology, it's definitely less invasive than a surgery, but there still are some things that we can talk about of how do we control your anxiety and can we give you some meditative type options and get your nervous system kind of calming down, and have you been walking, and what's your strategy for breathing, and what do you do if you get a little anxious when the nurse pulls out the needle to put the IV in. We talk through all of that stuff and try to prepare you well, not even specifically to pelvic health, but just that whole prehab to prepare for a good outcome. So I would say everyone, Gabi, if you really asked me, I would love that. The option of what do we do then? We talk through what it might look like. We talk about the sounds that you might there's a lot of people that have never been into the interventional radiology circuit or space or into surgical kind of pre and post-op recovery areas. So trying to give them just all of the education in that extra time that we have to spend with patients is hugely influential. Can we talk about making some meals beforehand? Can we talk about all of the things that you're going to do to set up your bowel regimen if you're going into surgery versus into an IR procedure? There's so many things that we can pull into that, including, do you know where your pelvic floor is and what might feel differently before and after, and what kind of hydration status should you be at before you go in? All of the things. So yes, if we could do all of it before and all of it after, that would be great. For speaking specifically about post-op recovery, I very much want to see somebody post-operatively somewhere around the 2 to 3 week mark to make sure that they're doing well with their mental health and with their bowel function, with their urinary incontinence. How are you templating out? No one expects you in the 6 week post-op lifting restriction to be a solid lump on a couch and a potato. That is not helpful at all. So what does that look like? Unfortunately, we don't have really a ton of data that says how good it is. The studies are starting to show it, but we know that we decrease blood clot risk, and we know that we improve people's mental health and quality of life, and we shorten their total recovery period after, which is awesome too. So we kind of set up the people that do all the fancy work on the interventional radiology and surgical suite for really good outcomes with their patients by partnering together. So, and it makes the patients feel like they have a lot more time to ask questions and things too. Obviously, if we run into something that's outside of our scope, we refer back and have nurses and physicians on speed dial all the time to ask those questions of their providers.
Love it. Knowing that pelvic PT can be a part of the entire process all the way through, which is really good to know. Dr. Grant, how does recovery compare between myomectomy and hysterectomy?
Actually, the recovery for a myomectomy and a hysterectomy is often very similar. The bigger factor is it an open procedure versus a minimally invasive laparoscopic or robotic procedure. I think in terms of with the minimally invasive procedures, with often done robotically, I tell people, that first week you have gas pain and that couple days of gas pain and discomfort, in a week or two to kind of where you're in pain and uncomfortable, but most people are moving around and kind of doing most of their activities in about 3 to 4 weeks, and often take about 6 weeks off of surgery or off of work. But often we're able to do a more minimally invasive procedure, and the recovery, is much quicker.
Great. And in comparison to how long is recovery after UFE, Dr. Astani?
UFE recovery is a little different. It's there is no incision and there's no cutting. We go through the vessels just like a small catheter placement, IV placement. We do everything through that. The procedure itself is not painful. It's just after the procedure when those fibroids don't get the blood supply, they feel it. They start shrinking. So patients feel a lot of cramping, a lot of I want to say contractions. They're not contractions, but it may feel as intense as contractions. And the first 3 days, it can be intense. There are pain medications for that, but a lot of the contractions, the pressure and sense of discomfort. The majority of that is 3 days. After that, it goes back to a normal symptoms of normal menstrual cycle and then goes away. By day 7, you're back to baseline. There is no hospitalization. It's extremely rare that patients stay in a hospital after a UFE. There is no general anesthesia. I encourage patients to take at a minimum 3 days off just to make sure that they are in the comfort of home as opposed to being outside or at work. In terms of physical activity, we encourage them to stay active, walk around, because that helps with some cramping and helps with bowel movement and things like that. If I get a chance, I want to address the question somebody asked about IUD. If somebody wants to have UFE, do we remove IUD and reinsert it back in IR? No, typically we work with the gynecologist or your primary care physician to take it out and put it back in. And that's why a multidisciplinary approach, again, it is really good. Somebody like Dr. Grant that is open to all the options and discusses all the options and sees the patients, refers the patient, accepts new patients. I think that would be the best approach. I want to do what I'm best at. I'm not best at placing or removing IUDs for sure.
Great. We've had a lot of really, really good questions, and I want to open this up, to the panel here and covering just how it looks like with what fibroids are, the treatment options that our specialists are able to perform, and then the quality of life and recovery after each of them. One of the first questions we had, I feel like we touched on, but I just want to make sure that we can address too, who submitted, I have bothersome fibroids. How do you determine whether my symptoms are actually coming from the fibroids? And how does that change what treatment you recommend? Dr. Grant, I want to direct it to you.
I think pain is sometimes a tricky symptom to say definitively, yes, your pain is from your fibroid. I think we can have an idea depending on the size and the location and an exam in clinic. But sometimes there are a little bit of trial and error. If you can do physical therapy ahead of time, and if you have a physical therapy evaluation and the pelvic floor isn't real tense, or it is and that improves, and you've made good success there, but that pain persists, I think that gives us a better idea of localizing the pain. Also, sometimes trying medication and temporarily shrinking the fibroid or improving the symptoms, again, can direct an idea that that's the cause of the pain. But we don't always know. And so we have an idea, but can't say for sure.
Right.
And the flip side is I think patients sometimes get very used to the pain or discomfort they have. And they kind of say, oh, I'm not really bothered by it. And something leads to treatment. The bleeding's too heavy or it's not controlled, and that gets treated. And people say, gosh, I'm going to the bathroom so much better and my pain's gone. And I didn't even realize that really I had, significant discomfort from it.
Great. Thank you. I have a question here for Dr. Stani. I've heard that fibroids can grow back quickly or it may not even work. Is this correct?
The fibroids can grow back, but they're not going to be quick. No, it's going to be a process over years, typically decades. So the fibroid development starts with the first stimulation of by hormones, and that happens at puberty. By the time they show their symptoms are large enough to cause trouble, patients are typically in their 30s or 40s. So it takes like long time, 15 years, 20 years to grow enough to be a problem. So yes, they can grow back. Typically, growing back is not quick or immediate. It's going to be over years if they happen. Most of the time, there are, as I mentioned earlier, there are smaller fibroids below resolution of our imaging, ultrasound and MRI, that those can grow and show up like 5 years later or many years later. And the other part of the question was they may not respond. Depending on the treatment, if you do a hysterectomy or if you do myomectomy, they'll respond. You're taking the tissues out. If you do embolization, you cut off the blood supply to them so they don't grow, they stop shrinking. So it's not that they don't work, but it is also true that over time in some patients, body can actually develop new pathways to those fibroids, new blood vessels to take over and supply those fibroids. So what we block off is the supply, the blood flow through the uterine artery, the blood flows that go to the uterus. In some patients, the ovaries start supplying the uterus. And in IR, in uterine fibroid embolization, we don't want to embolize the ovaries. We don't want to affect the ovarian supply and ovarian reserves. So if in some patients, it's not common, it's rare, but if the blood supply is coming from ovaries, then we have to be thinking twice about if UFE is the best option.
Here's another embo question too. Can you get embolization after myomectomy if the fibroid came back?
You can get embolization after myomectomy, yes, and vice versa. Is that correct, Dr. Grant? You can get myomectomy after?
Yeah,
UFE
definitely.
Great. So who submitted it? There's options out there.
I think I'd maybe just chime in, Gabi, just one sec about
Yeah.
after those higher level procedures with UFE or myomectomy or hysterectomy, if you're still having pain or dysfunction, there's something else going on, either nervous system, tissue-based things. That's a huge proponent then for pelvic health PT of dive deeper. There's something else going on. I don't know, Dr. Stani, if you're planning on touching on it at all, but how the overlapping condition of pelvic vein dysfunction or other kind of pain-provoking things can potentially show up as something similar in nature of that. That might not be the topic for the conversation today, but there are some other things out there that can be ruled in or out. Yeah.
I think it may be worth just generally touching on it because it came up a couple of times. Pain, Dr. Grant said it, you mentioned it just now. It's a vague symptom, can come from many different things. Can be from the spine, from the nerves getting pinched anywhere on the way. It can be from muscles, muscle tensions or spasms. It could be from joints, right? From hips, for example, as referred to the pelvis. It can be from the uterus, and from the uterus, it could be fibroid, could be adenomyosis, could be endometriosis. They can come from bladder. They can come from bowels. They can be from many different things. And one cause is also called pelvic congestion syndrome or chronic venous insufficiency. That's where those varicose veins develop, very similar to the varicose veins in the leg. but it happened deep in the pelvis. So pain is very tricky. If you have your fibroids treated and you still have pain or pressure, yes, there are many other things that can be contributing to that. And also, I want to mention that if you have myomectomy and there are a couple fibroids left, or if you have a UFE and one of the fibroids is not treated because it was getting supply from the ovary, that doesn't mean that your symptoms not going to go away, because studies have shown that if you reduce the size of the fibroid by 30%, meaning that only 30% shrinkage in the size of the uterus, most of the symptoms improve. UFE on average provides 60% shrinkage. If you have myomectomy, they may remove, for example, 2 fibroids completely, entirely, 100% of those fibroids are gone. And maybe there's another one left that it was deeper inside. But just having fibroid or having one left doesn't mean that your symptoms are persisting. Again, most women have fibroids. Most women don't have issues with them. Just having fibroid doesn't mean that they're source of the issue.
Great, Dr. Grand, do you have anything else to expand? I just figure since the conversation got brought up.
Yeah. No, I think he just was finishing the point of pain is a really tricky symptom and sometimes hard to get to the bottom of.
Mhm.
Yeah, if I could put a plug in
yeah.
for all of the folks out there that might still be dealing with pain type things, is keep searching. Keep searching for a provider that if you're not being listened to, please don't let people gaslight you into like just having to live with something. Make sure that you're in the right people's offices to find the specialist that really can work things up that way. And one other area that didn't get brought up, but central sensitization, where there's actually changes in how the peripheral nerves interpret symptoms and then how that then map throughout the rest of the spinal cord and into the brain can change after you've had a chronic symptom, especially pain, for a while. So all of the tissue stuff might be completely ruled out, which is great, but then you're still left with a sensory experience that is very large. And that is something that can be helped with physical therapy as well.
There was a question that asked about pain management and what that's like after post UFE. Is recovery hard?
Post UFE recovery. Pain is managed. There are plenty of pain medications we give them. Pain is not the issue with post UFE. The sense of I want to say pressure sensation is going to be there. So I typically tell my patients, I think of the worst symptoms you get at the peak of your menstrual cycle. You're going to have that. It's going to be really bad, really intense for 3 days. It's not necessarily pain, but it's that sense of pressure and spasm and sensation of basically not feeling well inside.
Another question too is my consult is coming up for IR. What should I be asking this provider so I'm ensuring I'm making the best choice for me? My longtime OB referred me because it isn't his specialty, and due to the length of recovery for a partial hysterectomy, he suggested IR since downtime could be minimal.
Questions to ask is just describe your concerns and your expectations and make sure that the procedure UFE can actually address your expectations. If there's a specific thing that you want to achieve, you want to ask your doctor to make sure the UFE can achieve that for you, because it may not. And that's basically true for every treatment. We want to make sure that the treatment actually gives you what you're looking for. Typically, in a consultation for UFE, we go over the symptoms, about the expectations. We want to review imaging. If there is no recent imaging, we have to obtain imaging. We need that for diagnosis, for mapping the fibroids, and for planning for the procedure to ensure a patient is a good candidate for that procedure.
Dr. Grant, I've got a couple questions here for you. Can I have a vaginal birth after myomectomy?
So if you have a myomectomy done hysteroscopically, so that is where you go in vaginally, you go through the cervix and you use a camera and you look, and you can sometimes resect the fibroid through the hysteroscope. Then you can have a vaginal delivery. If you have a myomectomy, then you need to have a C-section. And kind of if you can have that, hysteroscopic versus robotic or open myomectomy is really dictated by the location and the size of the fibroids.
Right. And does other forms of birth control besides IUD have an impact on fibroids?
Yeah, oral birth control, hormones. So the oral birth control pills, the patch, the ring, they all can decrease bleeding and pain associated with fibroids. They generally don't affect the size, or if there's a bulk symptom that may not be improved, but the bleeding definitely can be improved.
Right. Oh, here's another one. Dr. Gran, would you suggest vaginal ultrasound or MRI for more accurate fibroid reading?
I think it depends on what the goal is. So I think initially starting with an ultrasound is really the appropriate screening test. It's easier to do, and it really gives us a good amount of information. I think an MRI can be helpful sometimes in planning for a myomectomy and also for the embolization. So generally starting with an ultrasound and then depending on if needed doing the pelvic MRI.
Right. These are awesome questions. I want to wrap up here. If there's anyone else that's got something here, feel free to shoot it in there. I want to make sure that we can get these addressed. Okay. I'm looking for alternatives to a hysterectomy for fibroids as I need to have an umbilical hernia fixed as the fibroids and enlarged uterus are taking up space.
I'm sorry, what was the question with that? Does she say that
Looking
again?
at alternatives to hysterectomy for fibroids as she needs to have an umbilical hernia fixed.
Well, I mean, I guess one question is treating the fibroids prior to doing the umbilical hernia. Sometimes people talk about a combined procedure, but with that hernia, you may need mesh. And so generally a combined procedure may not be indicated, but I think doing the embolization, doing an IUD, some of the medications, the GnRH agonist or antagonists can be used. Those generally are not used long term, but I think that that's a longer conversation in terms of kind of how big the fibroids, where are they, and what's going on with the hernia surgery.
Sure,
If the
great.
question is about hernia specifically, hernia repair is an entirely different procedure, different surgery. But it is a good idea to decrease size of the uterus, the fibroids first by any treatment, hysterectomy, myomectomy, UFE. So there's less pressure, less intra-abdominal pressure. So there's less pressure to bulge things through the umbilicus. So after hernia repair, the success rate would be higher, or the complication rate could be less.
Yeah, the biomechanics of how you can improve your abdominal wall for firing once that space is alleviated from taking up, similar to a woman going through pregnancy and delivery. They feel kind of empty inside. If you have a decent amount of mass of fibroid or uterus removed, or even if they shrink over time, that can be a change in the abdominal wall length tension relationship that can be helpful. I have had some people in clinic that post partial hysterectomy end up not having to have a hernia repair because we restabilize their abdominal wall after that internal, like voluminous pressure is relieved too.
Fabulous. Someone said the only side effect I have 16 months after my UFE are yeast infections every 45 to 60 days. I know they have nothing to do with another, but I read somewhere there could be dead tissue from the dying fibroid causing the yeast infection. Dr. Stani, if you just want to expand on that.
So dying dead tissue in the fibroids after UFE is extremely rare. So basically the medical term for that is necrosis. Necrosis of fibroid is extremely rare. That creates, for example, a cavity that gets infected for two reasons. Number one, there hasn't been an opening, there hasn't been an incision to introduce external elements into the fibroid, into the uterus to cause infection. So there probably other reasons for that. It's not impossible. It's not a common or something that we talk about or consider. It is still possible, like infection anywhere in the body is possible, including in the fibroids, including in the treated fibroids. But that's extremely rare, and that's not likely. I would start looking elsewhere for this cause of infection. But I think the other part is after fibroid treatments, after embolization, if those fibroids are protruding into the canal or they're immediately under the mucosa, sometimes some of those tissues die off and slough off and come out, just like some discharge. That's temporary. That doesn't cause any symptoms. Meaning that they come out and it's fine. If they don't come out, then that's the problem. And they don't come out if they're larger and they can't pass through. And I think Dr. Grant mentioned a case that the patient had something protruding in the canal and she had to do a hysterectomy to remove those tissues.
Well, that was a hysteroscopy. Yep. So the minor procedure where you go in looking with the camera and you can just remove that in a more minor procedure.
Right. I think we've addressed those here within the chat. I just want to thank everybody, our experts that are here, a part of this panel today. This is something that we, don't come across a lot, and I want to really thank all of our participants for joining us today and thinking about this. We want to be able to have this as a place of empowerment for women, not just here within the Twin Cities who have access to these experts, but additionally to those that are within the nation that can find a collaborative panel. Who we end up choosing for our care makes all the difference of our outcome and our increase in quality of life. I just really want to thank everybody for participating about this type of, fibroid care and treatment options that are available to us. Lastly, just in conclusion here, I have a slide that I want to throw up to everybody. It's just for additional contact information so that if there's anything that maybe you can't think of right now, but later on you want to, approach or call in the clinic, make an appointment or second opinion, I want to be able to have everybody have access to these providers. I'm going to share my screen here. We're going with some QR codes. So go ahead. This is for information to scan. It has the website and their contact information that's available here. And I'll be sure that the panel gets uploaded to our YouTube channel and that every registrant ends up getting the follow-up email. Is there anything else you three would like to add?
Just want to thank everybody who participated. Excellent questions, and thanks to Dr. Grant and Kelsey as well. Thanks, everybody.
Yeah, thank you all. Feel free to reach out if you have questions. Happy to answer via email or call.
All right. Take
Thank
care.
you, everybody.
Thank you.